Yes, so I don't know where I got up, so I'm going to recap this quickly. So I said that to determine whether the heart is enlarged or not, you measure the longest diameter of the heart and divide by the longest diameter of the thoracic cage. And it should not be more than 0.5 centimeters. It should be even less, or not in meters, just 0.5. Right? Now, you realize that the heart, we could just take a straight line and measure all the way here. But the reason we don't do that is because the longest border on the right is not at the same level as the longest border on the right. That is why we rule a line and make the measurements separately. So the longest border on the left is not at the same level, because if you watch critically, if you were using here, realize that you end up here, and this place is shorter than here. And if you're using here, then your line would extend here, and this place is shorter than here. So that is why we don't use a straight line running across the heart. However, for the thorax, we use a straight line, but for the heart, we don't do that. If you do it like that, you will get it wrong. It is not done. Good. So basically, that is what it is. So longest diameter here plus longest diameter here over this, and you should be getting less than 0.5. Okay. All right. Yes. So there are certain rare anomalies in which the what do you call it? The heart will not be on the in the normal position. We know the heart is supposed to be on the left, but sometimes you take an X-ray and realize that it's not on the right. Okay. Yes. So now, when we say situs solitus, it means that the organs in the body are not in their regular positions. And dextrocardia, of course, I'm sure you all understand what dextro means. Dextro has to do with right. So if you have a heart that is on the, you do an X-ray and you see the heart on the right, we call that dextrocardia. Dextrocardia. All right. Now, yes, so you can have dextrocardia with situs inversus. So this dextrocardia, that is the heart on the right, and all the other organs are also reversed. Okay. Where is it? Yes, so you can also have dextrocardia, but with the other organs in their normal positions. All right, so all of these are variations that you see. All right. Where? Okay. So those are just some of the abnormalities that you can have with the heart position. It's just good to bear in mind so that if you get an X-ray that's abnormal, you can quickly pick it up. All right. Okay. Now look at the X-ray on the left. The X-ray on the left here, that's my left. Your left too. I can see that the X-ray is labeled left. So the left is supposed to be here. So you realize that the heart should be here. The left part, the left ventricle and the right should be here, but it's not. And we know this is the left because the gastric bubble is here. Can you all see the gastric bubble? Here's the gastric bubble here. Gastric bubble. Gastric bubble. So that means that this is all of the left. This is all of the left. Okay? But the heart is on the right. Is that okay? And over here too. Now this is a whole, so this is a typical example of dextrocardia with situs inversus. Okay, so this is the right, this is the left. So you see on the right, the heart is pointing, I mean, it's on the right here, and the abdomen is also on the right. So this person, all the organs are turned or positioned the opposite way. So this is situs inversus, and the heart is also on the right. So you can say dextrocardia with situs inversus, or dextrocardia or complete situs inversus. Let's remember that situs solitus refers to the normal location or position of the organs. Okay. Now, going to the lungs. Hold on just a minute. Okay. So the lungs. Yes, so the lungs, we usually divide them, of course. We've done this in your anatomy, we've done this in medicine, in surgery, and so on. So we don't waste too much time. But the lungs, we have the upper zones, the middle zones, and the lower zones. Typically on the chest X-ray, you expect the upper lobe to be from the apex down here all the way to about the second rib anteriorly. Then the middle lobe will be from the second all the way down to about the fourth. And then the lower ribs will take from the fourth rib downwards. So this is the right upper lobe. Okay. This is the PA view. This is the lateral view. This is the right lower lung. Okay, this is an AP view, this is a PA view of how it looks like. All right, and this is a presentation of how the major and minor fissures divide the various parts of the lungs. The right lung is divided into two lobes. The left is divided into the left is divided into two lobes. The right is divided into only two. Oh, what am I saying? The right lobe of the lung is divided into three different lobes, and obviously because there's no heart there, there's more space there. Whereas the left lobe of the left lung is divided into only two. Okay, so this fissure separates the lower lobe out from upper lobe and then the middle lobe. Yeah. Okay. So pretty much the same thing. So these ones, when you get a slide, you take your time and study them. What? So I've already said that the left lung is divided into only upper and middle lobe, upper and lower lobe. Okay. So yeah, and the pulmonary vessels. So the pulmonary vessels, these are a bit more difficult to see sometimes, but however, we'll just learn them and just to know them for knowing. Sometimes in certain pathologies, like in heart failure and the rest, you realize that the lungs, the great vessels become enlarged or prominent. And you find the vessels on the hilar surfaces of the X-ray. So the hilar are here. Okay, so the hilar are the medial surfaces of the lungs. Okay, so the pulmonary veins and the rest are all on this side of the X-ray. Okay. What do you need to know? What do you need to know? Yeah. So these are readable things about the pulmonary artery and the rest. Now, things of note, or the important things I want to see on the with regards to the vessels are when there are there's pulmonary congestion. I'm sure you've done heart failure, so you know what it is. You heard about Kelly B lines. They're a bit difficult to see on the X-ray, but on when the person has heart failure, you realize that there are some opacifications towards the bases, and then you see some more straight lines or pacification. That's what I'm referring to as lines. And some of pacifications here that are largely due to edema of the capsules or the fissure, the fluid collection in there. That is what shows on the X-rays as such. I'm sure you can get better pictures online and see, but this is one here. I don't know if you can all see this line here. So these are Kelly B lines. There are also Kelly A lines. Okay, there's another one here. Okay, and you can see that the hilar set, unlike, okay, this one. Okay, so no, not this one. I want a clean X-ray. Okay, so now on this X-ray here, I hope you can all see these are the vessels that are here like this. Okay, now these X-rays too are looking like they have pneumonia. If you will note carefully, you realize that this X-ray here, this part looks more translucent than here. So I see that the lower or the bases are more radio opaque. This is how pneumonia of the lower lungs will look like. So you can see that it's more radio opaque as compared to a more translucent area up here. So this is pneumonia of the left lower zones of the lung. Okay. Now look at how the vessels are shown here compared to this ones here. The vessels are more prominent. Okay, are more prominent. So you see that these ones, the vessels are ending close to the hilar, but when there's heart failure and there's congestion of the pulmonary vessels, you realize that the vessels will extend more into, you see it more in the parenchyma of the lungs, as can be seen here, okay, along with your Kelly B lines. And there's what we call cephalization of the lung. That is, the vessels appear more straight. They seem to be sort of like a funnel collecting from upwards. That is what you refer to as cephalization of the vessels, and these will be seen. Now, the pulmonary artery is a vessel that is closely, hey, my cursor is gone. Let me get my cursor back. Yes, so it's closely approximated to where you'd expect to see the left atrium. Okay, so it's lying closely here. Now, when the left pulmonary artery is enlarged, then you would see what looks to, or seems to be, how do I put this in English? Roughly. Okay, so you can see that this line here, the left border here runs smoothly. There's no prominence anywhere here. All right. And also you can see on this line here that there's no prominence on this side here. Okay. But let's look at this X-ray. You can see that there's a prominence here, something just abutting out. When you see this, it's pathognomonic for an enlarged pulmonary artery. Okay, and this could be due to, in cases of pulmonary embolism and the rest, you see that the pulmonary artery will get enlarged. What? Okay. Yes. So one other way by which you differentiate arteries from veins are that veins usually have a horizontal, have a more horizontal course towards the left atrium, whereas the arteries may be diagonal and so on, or vertical. Yes, so same pictures. Kelly B lines still showing here on these X-rays. So you can read about Kelly A and Kelly B lines. Some of the main differences you want to note are the fact that Kelly A lines are oblique, Kelly B lines are more transverse. Okay, and Kelly B lines are usually seen in the lung bases towards the periphery, whereas Kelly A lines are usually seen closer to the hilum. Just are the main things of note. Okay. So her sign, we can say that. Okay, can you read this one? Okay, so now let's move on to the diaphragm. As I mentioned, the diaphragm are very important when you need to diagnose some of the common things like pleural effusion. Now, note that the right hemidiaphragm is slightly higher than the left, simply because of the liver, which does not move. It doesn't shift, unlike the stomach that can be sort of movable depending on the content, okay? So on inspiration, the domes of the diaphragms are at the level of the 6th rib anteriorly and the 10th rib posteriorly. The things that you should look out for on the diaphragm, so this could be an exam question. What are the things you look out for on a chest X-ray when you examine the diaphragm? So you want to know whether the costophrenic angles are crisp. That is, are they appearing sharply? Can you see the, okay, so can you see this whole corner here? Is it very sharp? How sharp is it? If it's a bit obliterated, it could be a sign that there's fluid in there. Okay, and where is that? Yes, and then the cardiophrenic angles too. Are they well, are they showing very well? Whether there's air under the diaphragms, as I've mentioned earlier, whether the diaphragms are also flattened out, or whether sometimes in trauma, when the diaphragms are ruptured, you realize that their normal architecture, their dome-shaped nature will not be there. Or sometimes if one hemidiaphragm is larger than the other, you want to know. And whether there's stenting where the diaphragm is unusually domed, these are things that you want to look out for. Now, these are X-rays that show pleural effusion. Now, you can see on the right part of the heart here, the cardiophrenic angle is there. The costophrenic angle is also there. However, if you look at the left, the cardiophrenic angle is absent and the costophrenic angle is also absent. So it appears as if the diaphragm on the left is higher. But in actual fact, it is just this fluid that has likely collected in there. Now look at this diaphragm here. It's that normally you see the angles to be sharp. You can see the exact point where they meet and form an angle. But over here, this is absent. But here you can see the diaphragm meeting the ribs sharply here, and also the diaphragm meeting the heart sharply in this corner. But on the left, it is absent. And that is how a pleural effusion looks like. Other examples here. So this here, you can see on this X-ray, you can see the right costophrenic angle here. Okay. You can also see the right cardiophrenic angle, but on the left, you are not seeing the the costophrenic and the cardiophrenic angles. And you realize that there is opacification all the way up to this level, and there's a meniscus here. Okay, there's a meniscus. So we call this an air fluid level. Now, typically, if going through the schema that we mentioned earlier, so you, for example, you say this is an X-ray of Kweku Mensah, who is 30 years old. It is a PA view. There is good exposure and there is no rotation. Okay. The trachea, what would someone say about this trachea?
Midline.
Oh, slightly bent to the right.
Slightly deviated.
That's good. So you can see that the spinous processes are here. However, the trachea, the spinous process is not directly in the middle of the trachea. That means that the trachea has moved. Okay, so it's slightly shifted to the right. And that is because of the pathology here. It is pushing the trachea away.
Hello, sir. Hello, sir.
Yes, speaker, I can hear you.
Yeah, please, I was waiting to ask something, but you mentioned it here. You said there's no rotation. Please, I don't get what the rotation mean on the X-ray, if you can kindly help me.
We're in the last lecture.
Hello, sir.
Yes, I'm asking whether you were in the last lecture when we did the started X-rays. Were you part?
Yes, please.
So we mentioned it the last time. We said that the medial ends of the clavicle, the medial ends of the clavicle, okay, the medial ends of the clavicle should be equidistant from the spinous processes.
Okay.
So
I
if
got
you realize that,
I got it, but I didn't know that that is the rotation.
so the person is turned on the side, then the person
Okay.
is sort of rotated. Okay. Yes, so
Okay,
as I
all
said, this is a chest X-ray of, as you may see, so and so years old. It is an AP or PAV, whichever one it is. And you see that the trachea is slightly deviated to the right. The costophrenic and cardiophrenic angles on the right hemidiaphragm are present. However, the costophrenic angles on the left, costophrenic and cardiophrenic angles are obliterated. They are obliterated, okay? And there is air fluid level at, so this is about the second, third, fourth. So there's air fluid level about the fourth intercostal space, okay, which is suggestive of a massive, or which is suggestive of a pleural effusion. Is that okay? Is that okay? So I've just given an example of how to comment on an X-ray. Any? All right. So that is how it goes. So this is how a typical pleural effusion would see. So you can see a homogeneous opacification. There's a homogeneous opacification of the left middle to lower zones of the lung. And because there's an air fluid level, that is this meniscus here, okay, we would say that this is a pleural effusion. And also because the costophrenic and cardiophrenic angles are absent on the left. All right. So this is another one showing here. You can see your costophrenic angle, cardiophrenic angle on the left, but however, on the right, it is not, these two are absent, and it's a homogeneous opacification here. And so this is a pleural effusion on the right. Okay. Okay, so these are other examples of, you can see that here the diaphragms are almost at the same level. However, we said that the right is slightly higher than the left. You can see your gastric bubble here. You can see that this diaphragm on the left on this X-ray here is higher, much higher than this. And there seems to be some fluid in there. This is how it would typically show when there's a diaphragmatic rupture and the stomach or other intestine move into the chest. Okay. And also, this is also similar. This would be described as air under the diaphragm. Of course, when there's air under the diaphragm on the left, it is not strange because we expect the stomach to be there. But when there's air under the diaphragm on the right, then that is diagnostic of pathology, particularly fluid in the abdomen. Okay, so some of the other soft tissues that you see on a chest X-ray are what we are showing on this X-ray. So you can see the breast shadows here. This is the breast of someone, okay? So it's a woman. I can give you an X-ray and ask you whether it is male or female. It's a fair question to see. And so for instance, someone who has had mastectomy of one breast, you would also see a missing breast on the X-ray. One will be present, one will be absent. All of these are helpful. And of course, the gastric bubble, as we mentioned, is important to alienate to give you a sense of direction as whether you are on the left or the right. And it's important to check for. Then also on the same chest X-ray, even though it's a chest X-ray, you can get to see any pathologies that might be in the axilla, such as tumors or swellings in the abdomen, in the axilla. And then, yeah, those are some of the main. And then when there's a lytic lesion of the bone, some of the leukemias, when they are eating away the bone, you could see it also has translucency in the bony areas. Okay, so then of course the bones are there, so you can also use this to tell use this also tell if there are fractures. So obviously this is a fracture of this clavicle, so this is the clavicle here and it is fractured. This shouldn't be difficult to tell. And then also we also use it to shoulder dislocation. When a patient has shoulder dislocation also, you realize that the normal anatomy of the humeral head and head socket here will be distorted. And those are what we use in making such diagnosis. Okay, now I mentioned anterior ribs and posterior ribs. So this is an X-ray that has clearly demarcated how the anterior ribs are and how the posterior ribs are. So if you watch, you realize that the rib is one. It starts out from the back and moves to the front. So the posterior starting, where it starts from the vertebra, is the posterior rib. Okay, and the curved one, the parts that are curved downwards are the anterior ribs. Okay, so the posterior ones are more horizontal, whereas the anterior ribs are more diagonal. Okay, and this is how the vertebrae are also looking like. Pectus excavatum, pectus carinatum. So these are some of the conditions that you find on an X-ray. I don't know if there's a picture here. Okay, so on there are some people that their chest, you realize that the anterior chest or the sternal area is caved in or is carved in as if they've received a punch inside. Okay, that is pectus excavatum. And there are some people who have what we refer to as a pigeon chest. The chest is unusually barrel-shaped, okay? And those are the pectus carinatum. Unfortunately, I don't think I have a picture here. So other pathologies that we want to look at. Now, this is a chest X-ray of tuberculosis. When COVID was around, some of the COVID X-rays also looked like this. But in the absence of COVID, if you see such an X-ray, it's likely to be tuberculosis, okay? When you marry it with the signs and symptoms. So this is, so we would describe this as patchy opacifications. These are patchy opacification. It is not uniform, it is not homogeneous. You can see that these opacifications are patchy. I hope you can all appreciate that. It's patchy all over. It's patchy like that. Can you all see? All right. So this is how a TB X-ray will look like. So this one, you describe it by mentioning the name, the age, the type of X-ray. Go on to talk about whether the trachea is central or not, whether there's adequate exposure, whether there's malrotation, and the rest. You describe the claustrophrenic and cardiophrenic angles. Then you go on to describe the pathology that you are seeing in the lungs. Okay. Easy. And this is how miliary tuberculosis looks like. Now, this is patchy opacification, but with the miliary, you see small. The opacifications are sort of dotted. We call it miliary. So it's like small dot of opacifications. I hope you can all appreciate the difference between this and this. So this is how miliary tuberculosis would look like. Okay. And of course, this is also a chest X-ray. And you can see the heart here, but there's also a small mass here. And this is how a lung cancer may look like on an X-ray. All right. And this is also another X-ray. Who can tell me about this X-ray? Somebody. Okay, so for this X-ray too, this is the main pathology here. You can see that the heart is here, all right, but there's a mass here. And this mass here is likely a lung cancer. Now, you can see another chest X-ray here. I think I need to change the heading for this one. Okay, let me just make it. Okay, so you can see on this X-ray here, there's a well demarcated area of translucency in here. Sometimes when you have a pleural effusion that is loculated and will not, loculated means that it is encapsulated, so it will not flow around, okay? If you let this person lie down and take the X-ray, chances are this thing will still be there. So this could be how a mass or a cancer, a metastatic cancer can show on an X-ray or a pleural effusion as well. Now, on this X-ray here, watch closely and notice that on the left here, there are normal lung markings. You can see the lung markings are there. The vasculature and the rest are shown here nicely on the left. However, on the right, there is no lung marking in this space here. Can you all see that there is no lung marking here? And there seems to be a structure at this point. Now, on this X-ray, the absence of the lung markings indicate that there is no lung tissue here. So what has happened here is that, and you realize that this place is more translucent compared to here, in the absence of lung markings. What's happening here is that the lungs have collapsed. So all of this is air filling the right part of the thoracic cage, and it's compressed the lung. So there's now the lung on this border here. So the lung is compressed here. And you can see also that the trachea is also deviated. That means that there's likely a tension pneumothorax. So the air is building up and it's pushing, it has pushed the lung all the way and collapsed it on the right. And it's also pushing all the way so that the trachea is also pushed away. I hope it is clear on this X-ray. Over here also, you realize that there are lung markings normally here. And over on the right, the lung markings do not take the whole of the lung. The lung markings are ending just somewhere here. So you realize that on this side too, the lung has collapsed and it's somewhere here, because beyond this side, there's no lung marking. And the lung markings are showing at this point. This is also a picture of a lung collapse. Okay. Now, this is a typical picture of a loculated effusion. So you realize that this is a capsule of a structure in here, mass in here, and you can see air fluid level. You can see fluid, you can see air. So this is a typical air fluid level. So this is a loculated mass. This is a better picture than the other one. So this one, for instance, you can't pass a chest tube. You probably need to find an ultrasound guided biopsy or aspiration of this fluid in here. Okay, so this is a mass inside here. When you see something like this, it is air fluid level. So the fluid which is heavier is down here, there's air above, we call it air fluid level. And there's a loculated mass. And this is how some of the cancers might look like, and sometimes even TB might appear in an X-ray. All right, so I think we'll end here. We are done with chest X-rays. So now what you have to do is basically, we have 2 minutes left. So basically you need to get more X-rays and go through them and go through them. Whenever you see an X-ray, you pick it up, look out for the various things that we mentioned, see if you can identify any pathologies, and do your best to describe them. And as I said already, it comes with experience. It comes with experience. You don't just do one lecture and pick it up. Even for us doctors, we don't even have any lectures on X-rays. We are taught on the ground and all of that. With a lot of experience and a lot of practice, you pick these things up. Okay? So you are quite fortunate to have a detailed lecture on chest X-rays. All right. So what I'll do is that because of the time, I learned you having your exams next week also. Next week or next week. What I'll do is I'll give you the slides of some of the next topics that we have to do so that you read them. Then when we meet, we'll just touch on a few things because it's not likely we can finish everything. So that if you read before we meet, then we can just touch on a few things that you do not understand and then take it from there. So, yes.
Yeah, please, the ophthalmology, not giving us a slide on refractive.
Yeah, I'll look for it. My laptop, as I've said, I've lost it. So I'm looking for some of the presentations when I find out.
Yeah, please, with the cardio thoracic ratio, the measurement is in which unit? SI unit.
We don't bring up the units. So okay. if you use a ruler to measure it in centimeters, at the end of the day, you don't measure. You just measure both in centimeters, or millimeters, but you don't bring it. It's a ratio actually.